All right, welcome everyone to our fourth week in Geriatric Bootcamp. This week, we're going to be talking about geriatric trauma within the nursing homes. We have Dr. Eva Newpain here with us, who's going to be talking for today's session. But before we get into that, we have just a couple of housekeeping items to get through. So if you're not familiar with who we are the iPro QIN-QIO. iPro holds the federally funded Medicare QIO contract for the region shown here. Specifically, iPro helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are three organizations under the iPro QIN-QIO banner. So if anyone asks if you know who iPro is or if you're working with iPro, you say yes. At this point, I'd like to pass it to Mary Ellen to give us a brief COVID-19 update. Mary Ellen?
Thanks, Josh. Can you hear me okay?
A little low, but I think we can hear you.
Okay, my internet's a little unstable, it's telling me. So, COVID update quickly. Hospitalizations have increased this week as of the 19th of August, up again 4.54 per 100,000 admissions. That's an increase of 18.8%. Deaths have increased as well, 17.6% since the prior week. The latest variants as of September 2nd, EG.5, continues to be the dominant strain causing COVID disease at 21.5%. The XBB strains continue to be the dominant strains in the US, and the EG.5 as well as the XBBB and also the new BA subvariant that we talked about last week all fall under the Omicron lineage. So the COVID vaccine that's coming out at the end of September, beginning of October, is a monovalent vaccine that will cover these strains. The Advisory Committee for Infection Practices, Immunization Practices is meeting September 12th to finalize the recommendations for the COVID-19 vaccine coming. So more news as we get it for you folks. That's it, Josh. Thanks.
Perfect. Thanks so much, Mary Ellen. At this point, I'd like to pass it over to Eva. Eva, over to you.
Thank you so much, Joshua. Hello, everyone. Welcome. I'm Eva Newpain. I'm a geriatrician at Brown University, and thank you so much for joining us today. Today, I'll be talking to you about geriatric trauma in nursing homes. I work majority of my work is an inpatient at this stage, but I had a privilege working as an attending physician in a nursing home setup where I served in skilled nursing facility, assisted living, memory care, and long-term care. Next slide, please. So today I want to talk to you about background about geriatric trauma, then we'll move on to assessment and management in nursing home level, and then common injuries that are seen in elderly population. Next slide. So here are a few scenarios that most of us who have worked in nursing home in any capacity have likely already encountered. Let me walk you through about these scenarios. The first one is a 70-year-old male admitted to skilled nursing facility following a right hip surgery. On his way to the bathroom, he fell. The second one is an 82-year-old female, a nursing home resident. She was found lying down on the floor. Next, we have a 66-year-old female, relatively younger, admitted to SNF following a hospitalization for pneumonia and acute kidney injury. She fell when she stood up from the toilet seat. And last, I have a 90-year-old male memory care resident who stumbled on his walker and fell to his left side. I'm going to give you 2 moments just to think what's the common theme here. Yes, first of all of these patients are geriatric patients. Second, they all fell. And then third, this all happened in a nursing home setup scenario. Next slide, please. So why do we worry so much about trauma and falls? The reason is because as the population shift is happening, people are living longer. We as healthcare professionals are now seeing more of trauma in older adults. These older adults are living actively in a community too. They are hiking, they are driving, they are going out on walkers. So again, that also predisposes them to trauma. But it's important for us to know that every second of every day in the United States, an older adult falls, making falls the #1 cause of injury and death from injury among older Americans. So falls are happening too often. Next slide, please. So why do we need to pay special attention to geriatric population? We know that trauma is a leading cause of morbidity and mortality across all the ages, but our geriatric patients differ from the younger counterparts because geriatric trauma patients, they experience higher mortality regardless of mechanism. So even if you think that they fell just from standing position, that can predispose them to dire consequences. Our geriatric patients are vulnerable because they might have greater number of comorbidities. They are at higher risk of severe disability and death. These patients are also likely to be on medications to manage their chronic issues, which might blunt their response to the physiological stress of trauma and increase the risk for complications. Older adults are also more susceptible to injury, even from minor mechanism, like they bump their elbow and they crack a bone. These patients are also less able to compensate from any injury. Next slide, please. So this slide basically looks busy, but I just wanted to walk you through. As of the report from May 2023, CDC still says that unintentional injury makes it to the top 3 killers for the population. And among the unintentional injury, fall and motor vehicle accident are the most common mechanism of injury among older adults. Fall accounts for a majority of injury, and despite the seemingly benign mechanism, in many cases, falls can lead to dire medical and economic consequences for older adult patients, including hospitalization, complication, and death. Motor vehicle accident is also the most common cause of traumatic mortality. The one message that I wanted to give from this slide was fall has consequences. That's the reason why every fall in nursing home needs to be reported and it needs to be assessed. Next slide, please. So we expect few changes as we age, which is part of process of aging. In case of older adults, their lung function tends to go down, their heart becomes stiff, the brain starts to shrink, and their bones start to become more osteoporotic. What it leads to is that they might have decreased reserve for respiratory insults to fight back. They might not even be able to mount tachycardia, their blood pressure might not reflect the real issue that's going on. And then again, with minor injury, they tend to crack their bones. So these all makes older adults very vulnerable. So we also need that's why we need to understand that the vitals that we check in nursing homes sometimes can be very misleading in older adults. And on top of that, if you already have someone with dementia or underlying cognitive impairment, the assessment becomes more complicated. Next slide. So not only the physiological changes, the older adults also have other confounding factors that might work against them. For example, they might be on medication that might mask their symptoms, or they might interact with other medication. Their kidney function might be different. And then their underlying conditions such as heart disease, liver disease, kidney disease, these all might increase their risk of death. Next slide. So what do we do whenever we hear trauma, or when I get called for a patient who had trauma in nursing home? Next slide, please. So assessment, as I mentioned earlier, vitals do not reflect the real scenario in older adults. So that's why there's a huge problem of under triage. That's the reason why any trauma patient, specifically if they are geriatric population, you have to think about transferring them to a higher level of care. In fact, we advocate that trauma in elderly should be evaluated at trauma centers, regardless of mechanism of injury. Vitals can give you a clue. For example, systolic blood pressure less than 110 or tachycardia, excuse me, heart rate more than 90 would be a clue, but you have to look at the overall perspective, how the patient is doing. And we know that these patients who are managed in higher centers, which are protocol driven, the outcome can be favorable. So we want every trauma to be evaluated formally in geriatric patient. Next slide, please. And then in the nursing home setup, whenever you encounter a patient with fall or any trauma, first thing first, you have to go assess the patient, get the story, get the history. And this sometimes is challenging, and or maybe more than sometimes in nursing home setup, especially if you're in a dementia unit, the patient might not be able to tell you the story. So that's where the collateral history comes into the play. The detail about the injury and fall definitely helps us a lot to plan the next step. So it's always a good idea if you could just ask, get a collateral history, ask what happened, how's the patient doing or feeling before and after the fall, check the medication, what underlying comorbidities they have, and it's always a good idea to document their baseline cognitive and functional status. For example, if somebody already had a residual weakness on one side from a stroke 5 years ago, I think that needs to be explained when you communicate with the next provider, because they don't know. They might think this is something new. And also always check the code status, because you are planning to do the next step. And if that doesn't align with their goals of care, then that won't work. So always check for their code status. Next slide. So in primary survey, the rule is still ABC. Make sure that the airway is clear, they're breathing. Supplemental oxygen is always a good idea. For nursing, I would encourage you to be mindful about the dentures, because they're always lying next to them in that console. So the reason is because bag mask ventilation is often more difficult once you remove the dentures, and also intact dentures should be kept in place should assisted ventilation becomes necessary. Next slide, please. And circulation, here the importance of vitals. Sometimes if the patient has been losing blood or their oxygen supply has been diminished for a while, they can manifest as confused, delirium, they might have poor urine output. These are few clues, but it's always a good idea to trend the vital signs. One set of vital never gives us a story. We need repeat vitals, trend it, and if possible, redo the vitals every 5 minutes. Definitely within 15 minutes, we want second sets of vitals. Next slide, please. And in primary survey, when you walk in and you don't know what to do and you suspect there might be some injury to the neck, make sure you stabilize. If you don't know, then wait for help before you move the patient. And again, we always want to know accurate assessment of the neurological deficit, but sometimes this might be limiting in the nursing home setup. And again, dementia is challenging. So if you don't know, get help. Don't move the patient, at least don't move the neck. And then monitor the patient, serial examination, vital signs, mental status, and reassess if there has been any new concern. Next slide, please. And secondary survey, so this is the word like primary survey, secondary survey, and even tertiary survey. We tend to use it a lot in a trauma world, because sometimes the manifestation might not become very evident when you first go and assess the patient. So it's important to reassess the patient within a time interval. And then up until you get help. A provider comes in, EMS comes in, you need to pay attention to this patient. Next slide, please. And then even before the patient is disposed to the next level of care, it's justifiable if the patient is having severe pain, you can start pain management right from the very beginning. If you're suspecting cracked bone, then analgesia is something that you should think about, because if you don't control the pain, the patient is miserable, and it can further complicate because it can cause delirium and distress to the patient. Now, usually as a geriatrician, we always shy away from using narcotics, but when the bone is broken in trauma setup, we also want to make sure that we do appropriate pain management. If they're able to take PO and you're confident about their swallowing status, then oral narcotic is justifiable, sometimes IV medication. We usually shy away because from the NSAIDs because of the concern for GI and renal side effect, but Tylenol is a pretty much relatively safe medication. In geriatric patients, we usually allow 3 grams in 24 hours. And then of lately, we are also using topical medications such as lidocaine patch. The other medication that's coming up and about is buprenorphine patch. So there are a few things that are available. Next slide. And then in nursing home setup, we can definitely do a routine imaging for non-emergent situations. So if you're suspecting something, but the patient is hemodynamically stable, we might be able to get some imaging, plain x-rays of the joints, or if something you're worried about. Lab, if we're worried about drop in your anemia, hypotension, then sometimes hemoglobin hematocrit can give us a clue. Rise in creatinine and BUN is another clue. We definitely want to check INR in someone who is on anticoagulation, and because supratherapeutic INR increases the risk of bleed. CPK is something we worry about if somebody was in a lying position for a longer duration. Many times we take care of patients who come with unwitnessed fall for unknown downtime. So CPK is something that we check to look for any sign of muscle injury. And then lactate concentration and blood gas deficit is something you can do, but these are usually not available in all nursing home setup, but something that can still be done. Next slide. Okay, now I want to switch gear and focus on few common injuries that you might encounter in a nursing home setup. It's okay. While you work on that, I can probably talk about, because the first thing I wanted to share was head injury. So we do see patients who tend to fall and then they bump their head. And you probably, whoever has worked in nursing home, we always ask, like, did the patient injure their head? The reason why we worry so much about head injury is because older age is an independent risk factor for morbidity and mortality in patients with head trauma, whether it's a major trauma or even a minor head bump. Most head trauma in older adults occurs from falls, and this is a typical scenario in nursing home setup. Many a times their GCS score might not reveal the exact situation, but the important piece is that every head injury in geriatric patient, nearly every, needs a head CT. So that's the reason why you might have heard that the patient needs to go out, it's sent out to the hospital. But at least in a nursing home, before you send out the patient, make sure that you review whether the patient is on anticoagulation and antiplatelet or not, because it's a very useful information for us if we're on the receiving end, because if they're already on a blood thinner, they will likely bleed. Next slide. And cervical spine injury, you heard me earlier that we need to protect the spine, especially the hyperextension injury can sometimes cause more complication. They can even impact the spinal cord and result nerve injuries. Unfortunately, these kind of injuries are common in elderly, especially because they might have underlying some spine issues like arthritis or even like degenerative diseases. So we need to make sure that their spine is well taken care of. Few modalities, sometimes when people don't know what to do, they might be able to roll up towels and put it on two sides just to secure it until the help arrives. Next slide, please. Chest trauma. So even when you imagine a patient who's about to fall, right, they might bump the head, and then usually the patients have a tendency to try to protect their hip. But think about chest and the rib. They are like pretty much outward. So unfortunately, rib injury is very common with chest trauma, and especially in those who already have osteoporosis, they might crack multiple ribs with these kind of injuries. So we worry a lot about rib fracture because they are associated with high morbidity and mortality. And depending on where you are, the trauma centers, you might have different protocol. Where we work in Rhode Island, the trauma team has a protocol of anybody above the age of 65 with 2 or more ribs, they have to come to a level 1 trauma center. Many a times the patient might say, I feel fine, let me go home, yet they are referred to trauma center because the mortality rate is high and they are at high risk of developing pulmonary complications. So they have to come here and get evaluated, but many a times they do get discharged to nursing homes for rehab. So what we try to be more aggressive whenever we're taking care of patients with rib fracture is we encourage their incentive spirometry, the breathing exercise. You probably have seen that IS or a cappella. We want to make sure we optimize their pain management strategies. We use multimodal analgesia, Tylenol, lidocaine patch, and narcotics, and continue to monitor the respiratory status. Next slide. Abdominal trauma. Abdominal trauma in elderly patients sometimes becomes very tricky because they might not have adequate pain sensation to report, and because of the laxity of abdominal wall, many a times the collection, the bleeding, or the stress might not become evident until it becomes worse. So if you're suspecting some kind of trauma or bleed, they are better served if they are sent to the hospital for further imaging and possibly surgical consultation, because earlier involvement, aggressive involvement might have a better outcome in these elderly. Again, before you send them out, it's super helpful if you review their medication, anticoagulation, and antiplatelet. Next slide. Pelvic fracture. So pelvic fracture, just like rib fracture and any other bone fracture, older patients with osteoporosis, they are at risk of cracking it even with less severity. Nevertheless, you have to know that every older adult patient with a pelvic fracture must be considered hemodynamically unstable until proven otherwise. Even if their vitals look fine, these patients have to be evaluated. Think about this pelvis. Not only it has the bony structure and its connection with the hip, it's also protecting a lot of organs inside. Bowel, bladder. There are a lot of organs that it's protecting. So that needs to be evaluated. We want to make sure there is no injuries happening there. So again, early surgical consultation and investigation might be required. And in nursing home level, many a times these patients get discharged to SNF or might land up in nursing home with non-op management. Just be mindful and be extra nice to them if they have pelvic fracture, because the basic positions like sitting and standing and lying might be very painful for them. And we also don't want them to develop pressure ulcers. So we need to keep them moving, but at the same time, we need to make sure that their pain is well managed. So please be mindful about their pain. Sometimes older adults might become delirious if they are not able to verbalize their pain. So just be extra cautious about that. Again, monitor the bleeder risk because there's a risk of pelvic hematoma, and then frequent repositioning, pain management, and bowel and bladder symptom assessment. Next slide, please. and long bone fracture. So we talked about, you probably have heard of hip fractures, and you probably have already taken care of a lot of patients with hip fractures. Unfortunately, in elderly, hip fracture is very common. Hip fracture has been associated with up to 20 to 24% 1-year mortality. So hip fracture eventually is associated with death. And then people with hip fracture tend to also lose their independence. Their studies have shown that they lose at least one part of their activities of daily living. And also hip fractures, if managed in a timely fashion, if this patient needs surgery, if we're able to do surgery within 48 hours, we might have good outcome. So that's why we are usually very proactive whenever we hear of fall and hip fracture, because they need to go to the appropriate trauma center so that they can get the right management at the right time, within the right time frame. But apart from hip, we also see other fractures of long bones, such as distal radius and ulnar fracture, proximal humerus fracture, and even clavicle fracture. Management for us, geriatrician and medicine part, is incomplete if we don't address osteoporosis, because not only it predisposes them for fracture, it also causes delay in healing. So osteoporosis needs to be considered. The vitamin D, especially if you live in New England, where we are, vitamin D and calcium supplementations are also part of core management. But again, in nursing home setup, whenever you go and you see somebody found on the floor, assess for swelling of the joint and look for if there has been any lack of movement in that particular joint, and if the patient is complaining of severe pain. So that's something that can help us guide that, hey, probably there is some broken bone inside. So it's always a good idea to look for that and document that. Next slide, please. And I think apart from those fractures that I just talked about, I also wanted to highlight that fall sometime is because of some other cause. Something could be because the patient syncopized, or the patient was having an MI and fell and cracked a bone. Sometimes they might be having a stroke, and that's why they fell. So fall can be a bigger problem too. And then the other big piece, I'm a geriatrician, so I had to put this because I'm very passionate about this second line, is that advanced age. And I repeat, advanced age is not an absolute predictor of poor outcome following a trauma, and should not be used as the sole criterion for denying or limiting care. Even if they are 99, they are able to walk. If they are in pain, it might justify a hip surgery. So you have to put the patient into perspective, not the age. And then last thing, this has happened to me multiple times. Many of my patients who are in nursing home, their code status would be DNR, DNI, except if they crack a bone. Meaning if they have like hip fracture, or they require some orthopedic procedure for just one time, they might be okay to revoke it just for that duration and go back to their previous code of DNR, DNI, or even DNH. I have taken care of a lot of DNH who came to the hospital just because of the hip fracture. All right, I think this is pretty much I wanted to share with you. I'm going to close it with the same patient scenario that we probably have seen, all these patients in nursing home setup who fell. So after this talk, I just want all the nursing home staff to realize that fall can be fatal. So every fall is a priority. Even if it's in your beginning of shift or end of shift, that patient has to be assessed. You have to trend the vitals, make sure you know the medications and their comorbidities, and their next step aligns with their goals of care, because timely disposition to higher level of care will save a life. Next slide. I will take questions now, and if you feel shy, or if you want to send me an email, this is my email address. I would love to talk to you through email too. I'll take questions if you have any.
So Eva, we have a couple of comments into chat I can share with you. So Dennis wanted to share that for the facilities to ensure that their care planning is clear and that their interventions are communicated to the direct care staff and on the care cards for all the aides. And then Lynn shares that tertiary survey is important. She just had a skilled nursing facility resident admitted with polytrauma whose wrist fracture was not identified while in the hospital and showed up when they started to ambulate with a walker in the facility.
Wow, that's a brilliant example. Thank you, Lynn, for sharing that. That is the reason why we need to do secondary and tertiary survey. Thank you for sharing that.
Does anyone have any other comments or questions that they wanted to share or ask Eva?
I was wondering what, if folks want to put in chat, I know we're kind of over time, but what is the biggest challenge when they're dealing with trauma in their facility? Is it pain management? Is it ambulation? Or when they're dealing with a fall, is it getting timely assessments and figuring out whether they need to go to the hospital or not? As somebody who takes these calls, that's one of the issues that I deal with a lot. Do I send them out? Do I keep them? Do we do neuro checks, keep an eye on them and vitals and see if they're okay? Can I sleep during the night knowing that they're not in the hospital? Those are the things I worry about. If anybody.
I can comment on that, Lynn, because with trauma, as we talked about, like there are a few trauma which needs to go out. Like, for example, you're suspecting pelvic, head, and if you're suspecting fracture, again, x-rays would be a help. But again, looking at the overall status, and I think it's important for the nursing home staff also that if you don't know, ask, get help. Because there's a lot, trauma is a lot. There are a lot of layers involved in the management. And I think when we work as a team, we can serve better. But definitely making sure that you're monitoring the patient closely. Just because somebody tends to fall a lot, we have taken care of a patient who falls like 5 times daily. And then sometimes I think people just get used to it, that person falling. But I just want to emphasize that every fall is an event. You don't know which fall is going to be the last one. So from our part as a healthcare provider, we need to do our diligence, physical examination, reassessment, trending the vitals, communicating. Communicating is another big piece.
So a couple more comments into chat. Sheila shares that frequent fallers are really tricky. And Stacy also shares on off shifts, it's hard to get the physicians to understand what we see and to act on sending the resident to the hospital. And then Linda shares, I do monitoring of falls and find that the staff does not always put in an intervention to prevent further falls and also do not put interventions in place upon admission of residents.
That's interesting. These are very relevant, has happened. So first comment, the intervention. So in ideal scenario, whenever somebody is falling that calls for an interdisciplinary meeting, it's just not a job of one person because it's not possible. I think if somebody is falling, then everybody needs to come together. In nursing home setup, again, most of the time we're taking off cognitively impaired patient. So a lot of things are already compromised, but involvement of physical therapy, occupational therapy, setting of a goal with goals of care with the family member or healthcare proxy, having a realistic expectation. So I think it needs a lot of care coordination. It's not possible for just that poor nurse to tackle the whole fall because it's a geriatric syndrome. It's not just a single one and on activities. So interdisciplinary meeting and strategy is likely going to help the patient more than a single nurse trying her best to do that. And then the other piece that you mentioned, that the communication with the physician. So because I'm on the other side of receiving call, one thing I can tell you, and that's the reason why I put all this information in the slide, is when I'm on the receiving end, I don't know the scenario. So the more story, the more background you give me, I would be able to paint a picture in my head. That's why getting the collateral history, reviewing the medication, last administration of narcotics or cardiac medication, blood thinners, these all informations help me to make the next plan, whether I send this patient to emergency department or I do a portable chest x-ray. So give me the information, give me at least few sets of vitals so that it helps me to understand the better, because you are my eye. I'm relying on you to help me manage this patient. I hope that makes sense.
Thank you so much, Eva.
Thank you. Thank you, everyone. I appreciate the attention. And this is my email. Again, shoot me an email if you have questions or if you want to know more about trauma in geriatrics.
I think Joshua is
Initiatives. I have our contact information right here. So feel free to reach out to us. We'll also, and if you know anyone who would benefit from seeing today's session, we do have this recorded and we'll be playing it again live tomorrow at 3:30. And we also have our IP3 session this Thursday at 11 as well. Eva, thank you so much for your time. It was truly a great gift for us all and the insight that you could provide. That'll be it for today's session. If everyone could just write in a quick comment if you thought that today's session was great, or if any feedback that you could provide, it would be really helpful for us, as these sessions do provide further insight for future topics as well. So thank you so much, everyone.
Thank you for your attention. Appreciate your time. Thank you.
Thank you.